All right. All right. Well, welcome, everyone. I'm Nora Turow from the University of Southern California, and I have the great pleasure of moderating this session. It's entitled Stemming the Rising Tide of New Viral Hepatitis Infections Globally. Really an important topic, given that in many countries, incident infection is really where the challenge lies. So we have an outstanding group of speakers to take us through this session. We're going to lead off with John Ward, who's going to be addressing the topic of providing a report card on incident hepatitis B and hepatitis C infections and the primary drivers of new infections by country of HCV elimination globally. John Ward really needs no introduction. He heads the Task Force for Global Health and really has been at the forefront of much of what we're doing in the elimination space. John?
Thank you. It's good to be here. It's great to open up this session on hepatitis B and hepatitis C incidents, and really the title of my talk really gives its objectives as well. These are my disclosures. And I think we're talking about Hep B and hepatitis C incidents because they're part of elimination goals for hepatitis B and hepatitis C that were set out by WHO in 2015 with the endorsement of the World Health Assembly. And those first goals were relative targets with reductions in the incidence of hepatitis B and hepatitis C of 90% between 2015 and 2030. In 2022, they updated their global strategy, WHO, to include absolute targets to reach declines below certain rates per 100,000, 5 per 100,000, and 2 per 100,000 for Hep C and hepatitis B, respectively. In addition, for those first goals, the UN Sustainable Development Goals included a target of reducing to less than 1% the prevalence of hepatitis B among children as a marker of preventing new infections, of 1% by 2020 and 0.1% by 2030. And then for the update in 2022, there was an explicit target for reductions of incidence among the population at highest risk for hepatitis C persons who inject drugs. WHO estimates there's about 1.2 million new chronic hepatitis B infections annually. About 2 out of every 3 of those new chronic infections are in Africa for reasons I'll show you in a moment. About 980,000 new hepatitis C infections, particularly in Southeast Asia and the Eastern Mediterranean region of WHO, particularly the country of Pakistan, which has almost 1 out of every 5 persons with hepatitis C globally residing in that country. I have to point out, as an old hand in public health surveillance, that surveillance of acute infections is tough. Many cases are asymptomatic for both hepatitis B and hepatitis C. We don't have a marker for acute infection for hepatitis C. Fortunately, we do for hepatitis B. And as a result, the case definitions involve a combination of clinical markers as well as laboratory markers. So surveillance is a challenge. I'm going to be using data from a collection of profiles that we have put together with partners in 32 countries in Chinese Taipei, bringing together data regarding their plans, their policies, their programs and progress toward elimination goals in those countries. And that process included an assessment of their surveillance systems. And I think it's important to note that only about half of those countries, and they're representing the large burden of hepatitis B and hepatitis C, only about half had systems for routine monitoring of hepatitis B or hepatitis C surveillance, particularly for low and middle income countries. So those are the data challenges that I think it's good to be mindful of. Now, as we look into what's the relative contributions of modes of transmission, we also are going to be looking at the way to interrupt those. We've had a hepatitis B vaccine since 1982. Been recommended for infants since 1992. That can be augmented by maternal screening and antiviral prophylaxis and other strategies. How do you interrupt modes of transmission in healthcare? By screening the blood supply and improving infection control. And then how do you go out into the community, such as for harm reduction, to reduce those exposures to hepatitis B and hepatitis C virus that can lead to transmission. So when you look at modeling to look at the relative contributions, as I'll show you in a moment, we've had a progressive scale-up in infant immunization that's already preventing new infections. The biggest task before us to use vaccine strategies is the improvement in birth dose coverage, which can have a profound effect in preventing new infections. And then that can be augmented by antiviral screening, HBsAg and HBe antigen screening of pregnant mothers in this particular modeling, and then antiviral prophylaxis for those mothers at high risk of transmitting, even if their infant receives timely birth dose vaccination, and you can achieve that 90% target. Now, infant immunization coverage is globally about 83%, with the lowest coverage in African countries as shown here. And then for birth dose, it's 45% coverage, with only about 1 out of every 5 newborns in Africa receiving timely hepatitis B birth dose vaccination. Now, keeping in mind this SDG goal of less than 1%, many countries have achieved that, as evidenced by these countries with profiles in purple and dark green. The light green is representing countries that have been verified as having achieved those goals by WHO regional offices that have a process for doing so. And then you see the countries that still have high prevalences. And this is also the case, in this other assessment, looking at the large number of countries in Africa that have that high prevalence because of that low vaccination coverage. So children in Africa have almost a threefold higher prevalence of infection because of this absence of prevention strategies. Gavi has recently devoted some resources to improve birth dose coverage, and we'll look forward to hearing more about that when Dr. Tomei talks. Looking at hepatitis C, a big impact on improving health care by blood bank screening and infection control, with additional improvements in reducing incidence by extending prevention strategies for people who inject drugs. There is a role of screening and treatment that can reduce that force of infection, adding on to that prevention benefit, and you can have a profound, large impact in reducing incidence. In terms of screening the blood supply, this has been a priority for several decades, in part driven by the response to HIV, and it's good to see that most countries now screen their blood supply in some way for these two infections. But as someone that spent a lot of time studying transfusion-associated AIDS, been very mindful of the window period between infection and detection by testing. And you can see, particularly for countries that have hepatitis C screening, they only screen for antibody, leaving a sizable window between infection and detection. So there's room for improvement. There's also a continued need to discourage people from using blood banks as a way to routinely be screened for HBV and HCV, because you're going to cause harm to transfusion recipients. Hepatitis hepatitis incidence has declined because of improvements in infection control, again, with adoption of universal precautions and other strategies, again, driven in part by the response to HIV. This is an analysis from about 10 years ago, showing large declines in the first part of this century. A more recent analysis that was shared with me by Adelina Ortini at the University of Bristol shows that there's an estimated, most recently, about 450,000 new acute hepatitis B infections because of unsafe healthcare practices, and about 50,000 acute HCV infections. So we still have a ways to go to improve it, but even though the modeling is a little bit different, the trend is definitely heading in a good direction. For vertical transmission, about 6 to 4% risk of 14% risk of transmission from mother to child. Again, by a recent analysis by Adam Trickey, estimates about 75,000 children become infected with vertically and around the world. In the U.S., I find it alarming that about 1 out of every 215 women giving birth have been infected with hepatitis C. That translates to about 29,000 women annually in the country and about 1,700 new infections. Fortunately, countries are progressively moving toward the adoption of routine screening for hepatitis C. We need to see more of that in the future, and unfortunately, U.S. is included in that. Turning toward regional and global estimates for HCV among people who inject drugs, this is a recent analysis, again, by Adelina Ortini at the University of Bristol, estimating that most recently, the incidence is about 10 per 100 person years, which is still high, of course, but it seems to be a decline in comparison to the data that are available in analysis from data that was collected prior to 2015. But again, she points out the paucity of data in many countries to really reliably track these measures. We have to be mindful of reinfection because prevention strategies continue to be important to protect reinfection. And you have estimates ranging from 3.8 to 6.2 per 100 person years in different prevention for people in drug treatment and those that have recently begun to inject drugs, respectively. This model estimates that there are about 1 million new infections among people who inject drugs globally. I find it really particularly remarkable that a sizable percentage of those new HCV infections are among people who inject drugs in the United States. So the U.S. is very much a driver of HCV epidemics among people who inject drugs. So we need to be part of the global movement to eliminate hepatitis C by improving our prevention strategies and our access to care and treatment for this high-risk population. And this is reflected here. There's been about a threefold increase in incidence in hepatitis C in the United States since 2011. In the most recent reporting year, fortunately, there was a small decline. We'll have to see if that point decline turns into a trend with additional surveillance data. But the decline was very marked among young people in their 20s. But even then, you still have an estimated 67,000 new infections every year, which is a large number, and with injection drug use being the predominant risk factor. And this reflects a lack of access to prevention strategies. This is, again, data from our profile countries that includes the United States, just showing the inadequate access to clean needles and syringes for people who inject drugs, with very few countries reaching the targets considered by WHO to be protective for people who inject drugs from becoming infected with hepatitis C. So in summary, I view elimination goals for HBV and HCV incidents as a way of promoting accountability and serving as a call for action, because it's really revealing what needs to be done or what's already been achieved. But we need reliable data to track that incidence in communities and for populations at highest risk, such as persons who inject drugs. The greatest progress has actually been with initiatives predating elimination goals. One of the sayings of disease elimination is that you can make progress before you set goals, and this has surely been the case here with the increases in infant immunization coverage over time and improvements in blood banking and infection control in healthcare settings. Our greatest challenges are those that have those populations and targets for improvements that have been adopted more recently. Achieving high coverage with hepatitis B birth dose vaccination and related strategies to fully eliminate mother-to-child transmission, injection safety in communities among people who inject drugs, and to see how we can expand access to testing and treatment to bring that treatment as prevention fully into a comprehensive set of interventions that can achieve these elimination goals around the world. I want to thank my contributors at the Coalition and also at the University of Bristol. And I want to thank all our partners in the development of the hepatitis elimination profiles in the countries that we've highlighted in this presentation. And I thank you very much.
Thank you, John. That was a fantastic start to this session and really sort of sets the stage beautifully for our next speaker. If you just click on the arrow, yep, there you go. So it's, again, a great pleasure to introduce. John highlighted that there's 1 million new infections every year related to in persons who inject or use drugs. In the United States, we're like a leader, unfortunately, in that regard, with over 300,000. So I think that this is a really timely talk. And there is probably no one who can deliver it more aptly than Jason Gribley, who's from the Kirby Institute. And the Kirby Institute has really led so many initiatives related to both understanding this population and really doing innovative work around how we can reduce incident infections. So Jason, we're delighted you're here. Thank you.
Thanks for the lovely comments, Nora. It's great to be here, and thanks for the invitation. Here are my disclosures, which were already displayed. All right, so I'm hoping to cover a couple things today. I think it's pretty clear that we have the successful tools to prevent HCV infection, but the major issue is that people really are not getting them, as John alluded to. There's been some amazing innovations in testing and treatment that have allowed us to get to same-visit testing and treatment. But I think one of the key issues is going to be how do we sort of maintain people on therapy moving forward. And I really think that we've got lots of models of care, lots of things that work, but we're really going to have to deliver them. We really have to scale and deliver these if we're going to achieve elimination. All right, so we have the successful tools to prevent HCV infection, but the problem is that people are not getting access to them. Here's some data from a systematic review led by Matt Hickman's group looking at opioid agonist treatment, so methadone or buprenorphine. And you can see here that resulted in a 50% transmission risk. And then if you add opioid agonist treatment in with needle syringe program provision, you can get up to a 71% reduction in risk. I do want to state that you need high coverage NSP, so that's ensuring that each person gets a clean needle or syringe for each injection. This is some really nice work that was done by Natasha Martin, and it's a difficult figure, but I'll run you through it really quickly. On the y-axis, you've got the number of annual treatments per 1,000 people who inject drugs, and on the x-axis, you've got the coverage of harm reduction. And in the shading tells you the percent reduction in prevalence after 10 years. So to give you an example, if you were to treat 3% of people who inject drugs per year and your coverage of NSP and OAT was 20%, you could get a 50% prevalence reduction at 10 years. But if you were to increase your coverage of harm reduction from 20% to 40% and your treatment from 3% to 4%, you could get a 70% reduction. So it just tells you, A, that you're going to get a greater prevention benefit if you use both needle syringe programs and OAT with treatment. And I think it also highlights that we're not going to be able to treat our way out of this. Here's some data from the Australian needle syringe program, which surveys a couple of thousand people who inject drugs from needle and syringes every year. Essentially demonstrate that in the period between 2010 to 2015, the incidence was 13.6 per 100 person years. And in the period between 2016 to 2021, that reduced down to 5.4 cases per 100 person years. So overall, a 58% reduction in incidence among people who inject drugs in Australia. It's really important to note that this is in the background of both treatment being rolled out at a population level, but also really high coverage of needle and syringes, almost 500 needles and syringes per injector per year, and a really high coverage of OAT, 87 per 100 people who primarily inject opioids. This is translated into a population benefit. So we've seen an increase in the number of people receiving treatment in people who inject drugs from 11% in 2015 to 75% in 2023. And this has corresponded to a reduction in the prevalence of current infection from 53% in 2015 down to 12% in 2023. But one of the massive issues is that harm reduction services remain inadequate globally. What you see on the y-axis is the number of needles and syringes distributed per person who injects drugs per year. And on the x-axis is the number of people receiving OAT per person who injects drugs. And only 2% of people who inject drugs actually live in countries that provide high coverage of needle syringe programs and opioid agonist treatment. If you look at the US, it's sitting down here, which is sort of at a low coverage of both interventions. And so as John was saying, if we're really going to have an impact globally, we really need to work at scaling up harm reduction coverage, particularly in the United States and some of these larger countries. And we do have some data and evidence now that treatment as prevention may have some benefit. This is some work that we did. This is one of the first treatment as prevention trials and led by Andrew Lloyd and Greg Dorr. This is the STOP-C study, and what we did was we looked at scaling up direct-acting antiviral therapy, so this is sofosbuvir and velpatasvir, over a period of time at 4 prisons in New South Wales, Australia. And what we demonstrated is that if you look at the incidence prior to scale-up, it was 8.31 per 100 person years, and this reduced to 4.35 per 100 person years in the period post-scale-up. So this was a 48% reduction in incidence. So it does provide some evidence to say that this could work. One of the key issues, as John pointed out, was hepatitis C reinfection. And so, again, treatment's not going to be enough. We need to be thinking about harm reduction coverage in these settings. And one of the big problems globally is that not only issues in terms of inadequate access to harm reduction in the community, but is inadequate access to harm reduction in the prisons. So if you take in the community, 45% of countries have needle syringe programs globally, and only 5% of countries have prison-based needle syringe programs. And if you look at opioid agonist treatment, only 43% of countries have access to opioid agonist treatment in the community and only 26% in the prison. So we really need to work on this if we're going to have a chance at sort of impacting the number of new infections and reducing this. All right, so we've also had major innovations in testing, which is exciting. This is a systematic review that was led by one of our postdocs, Evan Cunningham, published in the Lancet Gastroenterology and Hepatology. You can see along the care cascade the different sort of steps, and then this is looking at different interventions to impact the care cascade. If it's a shaded box, it essentially said that there was 2 or more studies that demonstrated that that intervention had an impact on that step of the care cascade. So what do we have in our toolkit? Well, it's really great. We've seen innovations in dry blood spot testing. So this is a finger stick onto a card that can then be tested for hepatitis C antibodies or RNA. We've got point-of-care RNA testing, and it's great to see in the US that the FDA, that we have a new point-of-care RNA test, the Gene Expert, that can be used here now. And we've got point-of-care antibody tests. So this is the finger stick point-of-care RNA test manufactured by Cepheid. Sorry, this is not how you do it in the US. This is the MiniVet, but you guys have a different device. But essentially, it goes into the cartridge, and this is a 4-door platform. And this is Francois, actually, at one of our syringe service programs with a couple of machines in parallel. And what we did was we performed one of the first study to evaluate sort of from a venous cartridge using a finger stick point-of-care test for current HCV. This now is led to the test that you currently have available with really good performance. And this has really been a game changer because it allows us to do single visit testing and treatment. It increases testing acceptability and reduces loss to follow-up. And in a program in the prisons, we sort of had a period of standard of care, and then we rolled out a one-stop shop model and essentially showed that we could decrease the time from treatment initiation from 99 days down to 6 days and increase the proportion of people initiating treatment from 22% up to 93%. Pretty remarkable. And then in a needle syringe program, demonstrated an 81% treatment uptake. So we've been rolling out point-of-care testing nationally now in Australia. So this is the Australian hepatitis C point-of-care testing program. The plan was to set up 65 sites nationally with 50 to 60,000 people tested, a range of different services, drug treatment clinics, needle syringe programs, prisons, mental health, mobile models, Aboriginal community-controlled health organizations. Testing's pretty broad, so anybody at risk of HCV are attending a service that provides testing. And then the program includes standard operating procedures, logistics, deployment, setup of the platforms, all of the operator training, quality assurance program, IT connectivity, and also a research and evaluation framework. So we've now got 103 sites active across all states and territories. That's a bit misleading because they're doing testing at multiple different locations. So that equates to about 391 services nationally, including we're in 36 prisons now. Done a number of high-intensity testing campaigns where we would go in for a week and test large numbers of individuals, trained 369 operators, and performed over 32,000 Hep C point-of-care tests and diagnosed nearly 3,500 people. This is an older snapshot of the data, but of the 2,450 that have reached sort of the time point for evaluation, 1,895 have been treated. About a third of these are for a retreatment, for a reinfection. And the overall treatment uptake is 77% within 12 weeks of testing. So a bit lower in the community, 50%. And we're actually waiting for some of this data to come back. We actually think it's probably closer to 65%. But what's remarkable is the uptake in the prisons. 91%, I told you it was 93% in a well-controlled trial. So real world data, the fidelity of that is pretty impressive. About 10% of all the treatment is now coming through the program, including about 23% in the state of Queensland. All right, so now we've got sort of these innovations in diagnostics. So how do we now support people to remain on treatment and achieve cure? Well, there's a couple of different things we can do. This is some of the interventions across patient engagement and care. So patient reminders for testing, patient navigation, coordination, patient education. I wanted to highlight a couple of new studies. This is some nice work from Sean Falanulia from Hopkins, presented at INSU last month, demonstrating that, so they did a study called RAPID, where they provided peer support in drug treatment programs, and they randomized people to either receive on-site treatment with peer support or referral to a local specialist. And what they demonstrated is that in the arm with on-site treatment with peer support, 89% initiated treatment as compared to 21% of those referred to a local specialist. The median time to treatment was 19 days as compared to 50, and 61% achieved cure as compared to 14%. This is another nice study from locally from San Francisco, the No One Waits study, so now. And I think this is something really interesting to be thinking about. One of the issues is obviously people not going to the pharmacy to pick up their medications. It provides almost another pillar in the care cascade. So what they did was they did a non-randomized, single-arm, open-label trial. So they screened with a point-of-care antibody test, did venipuncture. Patients came back 1 week later, and if they were positive, they got a 14-day starter pack of sofosbuvir/velpatasvir, and they took that first day on enrollment. Look, I know this is a bit of a challenge in the US with some of the issues around prior authorization. We're a little fortunate in Australia. We should be able to implement this a bit easier. But anyways, patients had 2 weekly visits, and essentially of the 111 that were RNA detectable, 80% returned for their RNA results, and of those, 98% initiated treatment. The cure was 67%, but the SVR in those completed treatment was 84%. So I think, it shows us that, some interesting ways to get people on treatment, but I think we're really gonna need more to support people through, and thinking about things like peer support, financial incentives, and other interventions. And then what about provider engagement in care? Well, we've got provider care coordination. So instead of the patients navigating each other, we're actually trying to coordinate the providers to make sure that they're going to the services that they need to. Medical chart reminders, and we know that provider education is important. I put up medical chart reminders because I think I call this a simple-ish sort of intervention. It's something that you can do. This was a combination of both physical, putting like sticky notes on files, plus electronic medical records, and it was the single intervention that had the highest effect size for increasing testing across the systematic review. So I think let's not forget the easy things to do, sort of a clinical audit, figure out what's going on, and then figure out a way to systematically ensure that those people are tested and treated. And this is the fourfold or 4 times greater odds of linkage to care. All right, so just in summary, just in terms of HCV prevention in people who inject drugs in prisons, I think the evidence is clear that needle syringe programs and opioid agonist treatment are effective prevention interventions, but the issue is that we're not delivering them at scale. This is for a range of issues around sort of politics and general morale around whether these are appropriate things to be doing, but they prevent infections, and we really need to be scaling them up. Treatment can provide benefit, but I think let's not sort of get ridiculous. In a setting where you don't have high harm reduction coverage, we're not going to be able to treat our way out of this. So treatment has to be coupled with adequate harm reduction prevention to ensure that we reduce the number of new infections. And I really think we need greater advocacy for the expansion both of opioid agonist treatment and needle syringe programs in prisons, because this is where a large majority of new infections are occurring. So in terms of testing innovations, I think that we've gotten near same visit. I know it's a bit trickier in the States in terms of sort of some of the prior authorizations issues, and even in Australia, not all of our treatments are happening on the same day for a range of different reasons. I think point-of-care RNA testing in the US is going to be really exciting. I'm excited for you that you're going to go on this journey, but I think it's really important to note that it's not going to be a silver bullet. We need other things that we can couple together. We're going to have to focus on ensuring that you've got the programmatic aspects in place to run the point-of-care testing. That includes the operator training, the IT, the connectivity, the quality assurance, those things, not when you're getting started, but as you build a bigger program. The starter packs are an interesting idea to sort of address this barrier of getting people to the pharmacies, but let's not forget about the sort of simple-ish things, so electronic medical record and other interventions that we know that work. And I think we need more innovations to support people through treatment. This includes more data around the impact of peer support. We need to continue to innovate. I didn't mention much about telehealth or remote prescribing, but that's a real important sort of potential incentives. And I just think I want to leave you with the point that elimination is really going to need us to move beyond these pilot studies, and we need to deliver these interventions at full scale if we're going to have an impact. Thank you very much. The work I presented is on behalf of a range of different stakeholders, nearly 150 people nationally. So I just want to say thank you to them, and thanks for your time. And
Outstanding, Jason. Thank you. Now, Jason said that we can't treat ourselves out of the infections within the prison system. Let's see what Jordan can do here. So Jordan Feld, again, someone who needs no introduction, professor of medicine at the University of Toronto and a good friend and colleague, fellow Canadian. And he's been given the task of discussing expanding treatment as prevention in both hepatitis B and C.
Great. Well, thanks, Nora, for the kind invitation, and to John and Nora for setting up this really important program. I think Jason really set the stage, and John really gave us an introduction of why this is so important. And I'm going to talk about treatment as prevention for both B and C. And Jason didn't talk much about B, so I'm going to talk a little more about B. Here are my disclosures again. And so what I'll just start with is the concept of treatment as prevention, and then go through treatment as prevention in specific scenarios. So clinical scenarios, specific physical settings. Jason touched on prison, and I'll touch on that as well because it's so important. And then also just actually thinking about how treatment in the general population, when it's really put to scale, how that actually influences incidence, and then some ideas for potential for the future. So treatment as prevention as a concept was really pioneered for HIV, and that's really where it made its initial impact when it was first put forward. I think it was met with some skepticism, but really the data have borne out that this has been an incredibly effective intervention for reducing HIV incidence and ultimately prevalence. So it's been very effective in the HIV world, and I think when you think about treatment as prevention, there's really two ways to think about it. There's the population at risk, so you treat people to prevent them from getting infected, and that's really been what's been used for sort of PrEP or pre-exposure prophylaxis, particularly effective in HIV. Very little data for that in Hep C, and probably, I would argue, not the way to go because of the curative nature of treatment for hepatitis C, but emerging data for hepatitis B, which I'll show you. In terms of the other side of treatment as prevention, where you treat the population with the infection to try to prevent transmission, this has clearly been very effective for HIV to both sort of reduce the population level viral load in a sense, and as Jason showed you already, this has been effective for hepatitis C, but not really scaled up, and I would argue there's been really limited data on this in hepatitis B, and I'll show you some things to think about when we think about this for hepatitis B. So I think where we've seen treatment as prevention to be most effective in the hepatitis B world certainly is in the setting of pregnancy, and a lot of data really showing that mother-to-child transmission, which is a major driver of global infections, as John highlighted, really can be reduced significantly with the addition of antiviral therapy in late pregnancy. And so all of us are familiar with the data on using HBV treatment in the third trimester in highly viremic women, with multiple studies showing importantly, it's important to look at these studies carefully, that in people in the intervention arms that you actually see no transmissions among women who were treated in the third trimester. And recent data have confirmed that you can use TAF equivalently to TDF, with a nice meta-analysis published this year showing that they are equivalent in terms of both preventing transmission and also safety for the mother and the baby. And we do have extensive safety data from the HIV world to give us confidence about using these therapies. What's been really, I think, pushing the envelope in this area is whether or not treatment actually can supplant some of our other interventions. And this is important because, as John highlighted, birth dose interventions are limited in much of the world. He didn't really talk about the fact that hepatitis B immune globulin is even more limited in many places. There are many places that don't have access to HBIG, in part because many deliveries take place outside of care settings, so at home, and this really limits access to these interventions. So this was a trial done in Cambodia where they looked at either highly viremic women who were e-antigen positive or were e-antigen negative with a high ALT, and they were randomized to get tenofovir starting earlier in pregnancy, from 24 weeks to 6 weeks postpartum. All babies were given birth dose vaccination, but HBIG was not required. And what they found in this study, and this was sort of a real-world study, was that for women that got more than 4 weeks of treatment, you can see that the likelihood of bringing down the viral load below that magic number of 200,000 was very high, 90%, and there were 0 transmissions in those groups. But if treatment was less than 4 weeks, and that's why they did intervene a little bit earlier here at 24 rather than the standard 28 weeks, you can see that transmission still occurred at a relatively high rate. But at least opens the door to considering this, as long as you can get it started early enough, that maybe HBIG isn't absolutely necessary. And I think a study which gives us a little more confidence in this approach was actually just came into press 2 days ago from Calvin Pan's group leading this RCT in China, where they took here highly viremic e-antigen positive women and they randomized them now earlier. So this is to 16 weeks, not 24 weeks, so 16 weeks to start therapy and to not be given hepatitis B immune globulin at birth, compared to the standard of treating these women in the third trimester at 28 weeks and to get HBIG. And this was a non-inferiority study. Importantly, all babies got birth dose vaccination. And what you see is that the rate, if you go by the per protocol analysis, actually there were no transmissions even without HBIG, and this was a very effective strategy. And in the actual intent to treat, there was only one baby who was surface antigen positive at birth, was DNA undetectable, and was lost to follow-up. Their endpoint was at 6 months after delivery, and some of these babies will clear, especially if they're not viremic at birth. So very effective intervention. And I think what's important here is you can see that by doing this start early, you can really reduce the viral load significantly in the women, and that's really what's driving the prevention. So I think this gives us some important data, particularly for low and middle income countries, where if no HBIG is available, starting very early, probably at 16 weeks, is an effective strategy. I think where HBIG is available, we should still use it, particularly in this population, and notably it was actually used as rescue therapy in the trial. So this isn't to obviate HBIG, but for places where it's not available. Now, what about treating hepatitis C in pregnancy? As John highlighted, recent data suggesting that there may be as many as 75,000 transmissions a year through vertical transmission, and we've seen, certainly in North America, really driven by the opioid epidemic, a lot more hepatitis C among young people, including pregnant persons. And so the guidelines, I think, actually have been very forward-thinking here. So first of all, recommending testing in every pregnancy, but importantly, also thinking about treatment in pregnancy with very limited data really supporting this, but I think being a little bit forward-thinking about whether this should be an intervention. And so you can see that the guidelines have this comment: despite the lack of a recommendation, treatment can be considered during pregnancy on an individual basis after a patient-physician discussion about the potential risks and benefits. And this is based on a pretty limited data set. You can see these small first PK studies and then case series showing, fortunately, very high cure rates, no transmissions, importantly, and at least no safety concerns in this small data set. So this is going to be supplemented by the ongoing STORK study, which I'm proud that we're part of in Canada, but it's also being run through the US. And this is evaluating women during pregnancy and then starting treatment between 20 and 30 weeks of gestation with sofosbuvir valproatovir, and then looking at prevention as well as safety, and of course the mothers and the babies. And so these are the data that were presented last year at this meeting, and you can see that at that point 32 patients screened, so this is actually more, the 27 enrolled is more than the combined literature in the global space prior to this study being started. And of those who had reached the SVR endpoint, all achieved SVR, and none of the babies had acquired hepatitis C. And you'll hear an update on Stork, which will be presented on Monday at this meeting, and I would encourage you to attend. Catherine Chappell, who's really done an amazing job leading this effort to understand hepatitis C treatment in pregnancy, will be presenting those data, and I can give you a sneak preview that they look good. So what about treatment of acute hepatitis C? And I think this is under-recognized as an important aspect of treatment as prevention, because we know that people with acute hepatitis C have a very high viral load, but in addition to that, the virus is actually much more infectious during acute infection. And we've really documented that this is true, and this is because the virus is not bound by antibodies. So almost all of the virus is infectious, and as little as a microliter can be infectious in the acute setting, whereas it might take a much larger inoculum in the chronic setting. The other thing is that someone that's recently acquired hepatitis C, by definition, has had a recent high-risk exposure and is very possibly likely to have another one. So it's important that the AASLD IDSA guidelines recommend that HCV treatment should be initiated without awaiting spontaneous clearance. And this is really important because we still see this when we're talking to providers that, maybe we don't need to treat all these folks, but this is really an important intervention, because when you treat that individual, not only are you curing their infection, but you're preventing ongoing transmission. And Jason talked a lot about the importance of treatment as prevention, or really cure as prevention, in the setting of people who inject drugs. And these are older data, but it really shows that you don't have to scale up treatment among people who inject drugs very much to have a really profound impact on prevalence because of the high transmission rate. And that really moves into the setting of thinking about prisons, which Jason's work has really been instrumental in documenting the impact of this. But I think these data from that STOP-C trial really showed us that treatment as prevention works. So this was, Jason showed you the primary data, and this is a modeling study that was based on the data done by Peter Vickerman's group, which really showed that the impact of the treatment in the prison setting, that they decreased incidence by 48%. And if they had no treatment, they expected that just by increased coverage in the community, they might have decreased incidence by 7%. So this really highlights the impact of not just relying on good coverage in your population, but very actively implementing treatment in the prison setting. And so they saw that really 85% of the reduction in incidence was related to treatment in the prisons. And this has been shown, this study was really a nicely controlled model to show it, but there's been other observational data, some really nice data from Spain showing the impact of treatment in prisons. You can see here, starting back in 2015, where they were screening most people, but they were treating very few, and it was only really with scale-up of treatment that they saw this first drop in incidence, and that ultimately led to actually a drop in prevalence. Very high cure rates, not surprisingly, but it's important to document. And then impressively, even in this relatively short time frame of 3 years of implementing this program, they actually saw a reduction in HCV-related mortality from treatment in the prison setting. The other advantage to treatment in the prison setting is that it has benefits when you move outside of the prison setting. So this is a modeling study, but it shows that because of the in and out of, that is very common among people who are incarcerated, that if you can engage people in treatment while they're in custody, and then when they go out into the community, you've essentially lowered the overall community viral load and reduced onward transmission. In this modeling study, it would suggest that actually treatment in the prison, and this was based on the Spanish data that I just showed you, that 90% of the impact was actually seen outside of the prison setting. So this is really, in terms of making the case to policymakers, this isn't only convincing your prison custodial staff to think about treatment in prisons, but also the public health more broadly because of the impact outside at the community level. So what about the actual impact of just increasing treatment. How does that influence things? And I think we all really look at Egypt and the tremendous efforts that they've done to scale up treatment at the national level. And that, of course, decreases prevalence, but this important study actually shows that it decreases incidence as well. So this is a study where this was led in collaboration with the WHO to really impact increased treatment among a number of villages in the Nile Basin where the prevalence is extremely high, and they were able to get very good coverage of screening and then engagement in treatment. And they were able to look at incident infection both before and after this intervention. And what you see is on the right is you see the incidence prior to their elimination efforts, where you can see it was about 2.4 per thousand. And then in the most recent look at this, after the scale up of treatment, you can see that incidence, not prevalence, but incidence drops by treating the population. And this is really important where we know that transmission continues to be ongoing because of unsafe medical practices. When you impact global prevalence, the probability that an unsafe medical intervention leads to transmission goes down dramatically. The important point about this, and I would really stress this not only for Egypt, but for anywhere that scales up their treatment, is this needs to be maintained. You really need to continue this treatment effort, because if you don't keep the prevalence low, the incidence will start to rise and the benefits will be lost. And so potentially we can do this in hepatitis B as well. There's really been an expansion of the idea of treating more people, mostly for treating the individual and their own personal benefit of reducing the complications of hepatitis B, but this may also have benefit at the population level by reducing transmission. And the WHO guidelines and the recent Chinese guidelines, which recommend expanding treatment criteria to most of the infected population, might have impact. But one little word of caution is that Hep B is not Hep C. So we have this notion in HIV of U equals U for people that are on effective antiretroviral therapy, that they actually can't transmit to people who, even if those people are not on PrEP. That might not be the same with hepatitis B. Now, these data are from a mouse study, but I think they're important. They took very highly viremic patients in the immune tolerant phase. They were put on antiviral suppressive therapy, got their level of viremia down to less than the lower limit of quantification, although still detectable. And what you could see is that taking just 100 microliters of serum from those patients, they could transmit to 29% of human chimeric mice. So it just really highlights that Hep B is not the same, and maybe if they were completely undetectable, that would have been effective, but it wasn't quite enough, at least in this setting, and it means that we probably have to do a better job of making sure we get vaccination. We do have a vaccine here, so we shouldn't rely on treatment as the only strategy, but PrEP actually does work in hepatitis B. We've known about it in HIV, but this is a study from Japan where they took people who were getting HIV PrEP and actually looked at the impact on hepatitis B incidence. And what they did show was that if people were taking PrEP, either daily or on demand, they could reduce the incidence of hepatitis B as well as preventing HIV infection, similar to what you would see with vaccination. And actually, they did see some seroconversions, although no acute hepatitis B infections with PrEP. And the final thing I'll finish with is the idea of actually expanding treatment by using long-acting injectable therapy, which could really be a game changer for hepatitis C, and also for hepatitis B in particular settings, particularly pregnancy, prevention of HBV reactivation in the immunosuppressed setting, and then PrEP and on treatment by really, again, being able to get treatment very broadly activated to reduce the overall number of people infected. And if we have curative therapy for hepatitis B, that will also have its effect. So to summarize, treatment is prevention for hepatitis B and C. I think for Hep B, the biggest effect in pregnancy. TAF or TDF are preferred, but you may think about early treatment, particularly if HBV is a challenge. Treatment to prevent horizontal transmission, I think it's important to recognize that U may not equal U, so a word of caution and really prioritizing vaccination here for partners and contacts, but PrEP can be effective. For hepatitis C, pregnancy is, I think, an important area where we're getting more data, and the STORK study will be really impactful here. talked about prisons quite a bit and really can't underestimate the importance there. And then at the population level, that this really can have impact by decreasing prevalence to decrease incidence, particularly among high-risk populations like people who inject and use drugs. And really, I would say that these long-acting injectables could potentially be a real game changer for preventing incident infection. So I would say treatment as prevention is not the answer, but it's an important part of the answer to try to get to Jason's goal of elimination. Thank you.
Thank you, Jordan. That was great. And it really sets the stage for our last speaker. So we're delighted to have Tanya Tomei from the Centers for Disease Control and Prevention. And she has been given the task of talking about vaccine-based strategies for both hepatitis B and C, set up perfectly by Jordan. So welcome. Thanks for joining us.
Thank you. Good morning, everyone. So moving to prevention of hepatitis B and hepatitis C infection by vaccination. These are my disclosures. And my talk will be mainly focusing first on addressing the gaps in strategies to improve coverage with hepatitis B birth dose vaccination globally, but also hepatitis B vaccination among adults. And then identifying potential strategies to achieve high hepatitis C vaccination coverage when a vaccine becomes available. So starting with the hepatitis B birth dose. As Dr. Ward presented earlier, despite significant improvements in hepatitis B birth dose vaccination coverage globally, the coverage is still low in most of the WHO regions, with the exception of the Western Pacific region, which have achieved the 70% 2025 goals with 70% coverage with timely hepatitis B birth dose. All other WHO regions have not achieved that goal. And the reason for that are various challenges. The main challenges include vaccine access and affordability, and this mainly impacts the sub-Saharan African region, where only 16 of 47 countries have introduced the hepatitis B birth dose in their immunization schedule. And hopefully now with Gavi support for hepatitis B birth dose introduction, this will be addressed in the coming years. The next challenge is the lack of awareness, both among healthcare providers as well as the parents or the caregivers on the importance of the timeliness of the birth dose in preventing mother-child transmission. In many regions, we still see a high number of home birth occurring, so how do we reach the home birth? And there are strategies that are successful that I will show. The increase in vaccine hesitancy also in many countries, and also the data quality in terms of how do we document the timeliness of the birth dose? In many countries, they do not differentiate a timely birth dose given within 24 hours of birth versus a birth dose given after 24 hours of birth. So throughout this presentation, I will go through some examples which have been documented in the literature. It's not comprehensive due to time, but really high-level examples. So in terms of the key component for health facility birth is quite important to identify, to have in place hepatitis B vaccination policies, have assigned staff dedicated for vaccination and the delivery wards, and also train the staff to give the vaccine, and timely vaccine. And this is an example from Manila in the Philippines, where they showed after these interventions were implemented, the staff were trained, they're provided with adequate supervision, the birth dose coverage improved significantly before and after these interventions for both children born at home as well as children born in hospitals. Similarly, in Nigeria, education of midwives and pregnant women attending antenatal care on the importance of the timeliness of the hepatitis B birth dose, as well as implementation of supportive supervision and reminders in the delivery ward can be just a piece of paper just highlighting for the midwives what they should do, significantly improved the median coverage with a timely hepatitis B birth dose from 2.6% coverage before these interventions were implemented to up to 62% a year later after implementation of these interventions. Now, we know like health facility birth, that's the easy way to kind of reach children with a timely birth dose. And that's how you need to encourage more women to deliver in hospitals or in health facilities, not only for birth dose vaccination, but also for good maternal and neonatal health outcomes. However, we know in certain places home births still occur because they might not have a health facility available for a woman to go and deliver, or due to cultural preferences. So there are actually interventions which have been shown and documented in the literature to be successful at improving timely hepatitis B birth dose vaccination, even for children who are born at home. And most of these examples are from the Asia region, and that's why we saw why the Western Pacific region had such a high vaccination coverage with timely birth dose compared to other regions, because they implemented some of these interventions early on. So this is an example from Laos, where they actually gave village health workers in rural areas, mountainous regions, with credits for cell phone messaging, where the village health workers know their people in their community. So whenever they knew that there's a birth in their community, they would call or message the midwives in the health facility, and the midwife would come and would bring the vaccine, a vaccine carrier, and they would vaccinate the child and also provide postnatal care. So that's one successful intervention. It showed like it improved coverage before and after implementation, up to 57% higher in the intervention districts compared to 20% in the district which did not have this kind of intervention, and that was statistically significant. Similar example was actually also done in Vietnam previously. Now, we know reaching home birth is difficult, but also there are some places where we don't have actually a cold chain to store the vaccine to start with. So how can we address this kind of challenge? There's also strategies that have been shown to be successful, and one of the key actually positive things about the monovalent hepatitis B vaccine is that it is an extremely heat-stable vaccine. It has the same immunogenicity if stored inside the cold chain at 4 degrees Celsius, or left 1 month outside the cold chain at 37 degrees Celsius, or 1 week outside the cold chain at 45 degrees Celsius. And this has been quite documented in the literature many years ago. Unfortunately, this has not been scaled up as much because the manufacturers haven't changed their label on their vaccine vials, because probably it's not beneficial. It's mainly sub-Saharan Africa. But hopefully now with Gavi support, maybe there will be more engagement on that front to support these kind of interventions and innovations. Now, another strategy also is making sure there are like optimal access to kind of vaccine presentation that could be delivered by people who are non-healthcare workers. Even sometimes the mother could give these vaccines. And one of them is the compact pre-filled auto-disabled devices. This is commercially known as Uniject. It's provided in Indonesia. That's where the vaccine manufacturer is. It hasn't been scaled up because of the cost. It costs around $3 per dose to deliver 1 dose of the vaccine in a CPAD versus around $1 per dose for a regular needle and syringe vaccine. The other potentially promising strategy is the availability of the dissolved microneedle vaccine patch. And this is like just a patch that people can apply. We have a good trial that has been done in the Gambia, which shows like quite successful immunogenicity for the measles and rubella vaccine. So hopefully there will be something similar for hepatitis B vaccine as well. So just some examples on use of the vaccine outside the cold chain that I will just provide here. These were early studies also done in Asia back during the early days when there was high rates of home birth, in these countries, and it clearly showed the success. They have here like 3 groups of children born either in a hospital or at home. And the first group was, given the vaccine stored inside the cold chain. They had to take the child, even if they were born at home, to the health center to provide the vaccine inside the cold chain. The second group was given the vaccine stored outside the cold chain with a needle and syringe. And the third group was given the vaccine using the CPAD device or Uniject device. And when we see here, like for home birth, there was a significantly higher increase in coverage after these interventions were implemented for group 2 and group 3, where the vaccine was stored outside the cold chain, compared to group 1. So that was clearly impactful in increasing coverage for home birth. A similar also example from Laos, where also they've implemented that in a region where most of the children are born at home, and it clearly showed significantly increased coverage with hepatitis B birth dose after implementation of the vaccine outside the cold chain. Now, in terms of vaccine hesitancy, in 2019, the World Health Organization listed vaccine hesitancy among the top 10 threats to global health. And there's no actually single intervention that would work in all instances of vaccine hesitancy. It depends on the magnitude and the cause of the problem, and these would vary depending on the country, on setting. And the strategies need to be tailored to the specific kind of setting. However, there's always a need for a combination of strategies to be actually successful at addressing vaccine hesitancy. And somewhat has been reported in the literature is basically raising awareness both among the parents, the caregivers, but also among the children at school. Early education about the importance of vaccination is quite important. And also having effective communication is actually key to building trust, dispelling fears, and addressing concerns and promoting acceptance of vaccination. having some reminders for the parents to come back and get their child vaccinated. And some non-financial incentives have been shown to be successful. And most importantly is actually having, implementing some social listening kind of sessions to identify the fears and misinformation before they spread and address them immediately. And finally, one of the key things we've been observing also globally sometimes that impacts vaccine coverage with timely birth dose is actually the birth dose is given at a time, when the neonate's at a high risk for, neonatal death, especially in certain regions. So there's really a need to develop preemptive communication messaging before, scaling up hepatitis B birth dose vaccination. And we've seen the impact of that in some countries where, a vaccine was given, the child died. It was basically a mistake of whoever gave the vaccine. They gave not the vaccine, they gave something else, but it was not actually communicated to the public, and they thought the vaccine caused death. So important communication and spreading the right information is quite important. So while everybody has shown that childhood vaccination is the key to kind of achieve elimination of hepatitis B globally. However, in countries where they actually have a high coverage with hepatitis B in children, also it's important to look at the adult population, especially most of the acute cases would be occurring among adults in that case. Many regions implement kind of risk-based vaccination for adults in terms of just identifying people at higher risk for infection. The United States is quite unique in terms of there's more like universal adult vaccination. So in this section, I'll be focusing on the United States to identify some strategies that would advance adult vaccination coverage. But also these strategies could apply to other countries. So this is in terms of rates of acute hepatitis B virus infection in the United States, we see the highest rates among the people aged 40 and older. And these are the people who haven't been reached by vaccination as children. So hence the need to actually implement adult vaccination. However, despite actually years of recommendations of hepatitis B vaccination among specific groups in the United States and more recently among adults aged 19 to 59 more broadly, the coverage remains suboptimal, even among healthcare workers in some settings. So some systematic reviews have compiled potential strategies to improve adult vaccination. Now, most of these studies targeted like influenza and pneumococcal vaccine. There's very few studies which actually looked at hepatitis B vaccine, and we need more data on hepatitis B vaccine specifically to scale up coverage in the United States. However, what these studies have shown is that the most successful interventions are those that use a combination of strategies in terms of provider reminders, education, setting performance goals for the providers, patient education, having alerts in the electronic medical records or the immunization information systems. This is the most successful. When you implement separate strategies, like in terms of separate provider education only or vaccination reminders only, while these are successful, they're not as impactful as a combined approach. Another actually very good approach to kind of improve coverage among adults is to allow, authorize vaccination for actually non-physicians, the pharmacists, the nurses, and other healthcare professionals so that they can vaccinate adult populations. Now I'll move to the potential vaccination strategies to achieve high coverage with a hepatitis C vaccine when these vaccines become available. And we need to use the lessons learned from vaccination coverage among adults and children from other vaccine-preventable diseases to look at the best approach. So based on what we see, the coverage in adults for all vaccines is much lower than coverage in childhood vaccinations. So we might need to focus more on the childhood or early adolescent vaccination, also to prevent infections early on. So this is the immunization schedule in the United States for childhood adolescents. So if we look at early on in childhood, already the child is getting 4 or 5 doses of vaccine at a single visit, and that's creating a lot of stress among the parents. They want to delay, they want to space out. So it might not be the right time to give this vaccine here. So we might need to look in early adolescence before the risk for hepatitis C infection might be coming higher. And here we see like the Tdap, HBV, and A vaccine, the first dose. They have relatively good coverage, so that's a potential area where to integrate hepatitis C vaccine, and that's around the age of 10 to 13 years. If we wait up to 16 years, that's the second dose of MNA that's given, the coverage is much lower, so the coverage would be dropping. So this is specific for the United States, but each country needs to look at their own immunization schedule and their own coverage to decide what's the optimal timing for hepatitis C vaccine administration. And this is focusing on a primary prevention vaccine, not a secondary prevention vaccine, so other strategies might be needed for that. So some lessons from existing vaccines is that, look at the target age, and optimize vaccination coverage, as I've shown in my previous slide. But also, the lesser number of doses you need, the higher the coverage you're going to achieve. And we've seen that with for example, the hepatitis B vaccine. 2 doses will achieve higher coverage than 3 doses of the vaccine. And then consider a combination of vaccine, combining potential hepatitis C vaccine with other existing vaccine. That might be also improving the coverage. And use lessons from the HPV vaccine, where early on there was a big kind of pushback against the HPV vaccine from parents and caregivers. And when the message was spread, this is a cancer-preventing vaccine, not a prevention of an infection that due to behavioral risk factors, it might be more accepted by the population and by parents. And then if a vaccine can provide a long-term protection after a primary series, of course, is going to achieve a higher coverage than one to require multiple booster doses to maintain immunity. So in summary, there are successful strategies to improve timely hepatitis B birth dose vaccination coverage as well as adult vaccination. However, there's a need to implement interventions and evaluate strategies to specifically improve adult vaccination with hepatitis B vaccine, and use existing lessons from adolescent and adult vaccines to plan for future strategies for implementation of hepatitis C vaccine to achieve coverage. Thank you.
If I could just ask all the speakers to come up to the front. We have time for questions, and it was a fantastic session. So I would invite individuals. There are mics in the center. I see that. So if you could move to the center to ask your questions, that would be terrific. I'm going to lead off because I'm going to sort of start where you left off around Hep C vaccines, because I think it's kind of we're all very interested in sort of how that future looks. So I would ask all of those at the table really to speak. But really, I think you've highlighted kind of one strategy, thinking about the adolescents and a prevention strategy. I've always heard discussion around vaccines as being really maybe a more targeted approach, where we're focused on those high-risk incident infection groups that we were speaking about today. So do you want to maybe just speak to that? And then, Jordan, can I ask you to give a little update on HCV vaccine studies?
Yeah, sure. In terms of the targeted approach, I think we've seen from the example of hepatitis B vaccine, the targeted approach didn't work because people will not disclose, risk factor exposure. And this is not only in the United States, but either other countries also globally. We've seen the same thing. So that's why when you do it more as a broader scale, and anybody can get vaccinated, you're going to achieve more coverage because people will not disclose that, we're just targeting specific groups of populations who might be at higher risk. So that's a kind of a lesson from the hepatitis B vaccine, how it started by being targeted and then it moved to universal.
Excellent. Jordan?
I agree with you entirely. I think it will have to be universal, and it is exciting to see at the Hep C, at the HCV Flavy meeting this year, there was a big focus on vaccination, and a number of groups have, I would say, promising candidate vaccines, which is good to see, and there's been increased sort of recognition of the importance of vaccination as part of the elimination strategy, so there's been a bit more funding allocated to this and prioritization. One of the big challenges for Hep C is really how do you test a vaccine, and that's why we've been exploring the model of doing a controlled human infection model and some progress in that to be able to test these vaccines, because it's really a monumental task to test them among people at risk, particularly people who inject drugs. It takes a really long time, really expensive, and if the vaccine doesn't work, you really lose a lot of momentum towards developing a vaccine.
I think we have a session here at 2 o'clock that's going to go into different models for vaccine development, just to do a plug for that.
Yeah.
Excellent.
Thank you, Lim, Singapore. Question for Jason. Very nice data you've shown for the injection users, but my question really about testing uptake. Don't have a lot of data in that, and what is a successful strategy to increase testing uptake?
Yeah, I think it's a really good question. We actually I don't have an answer for you. We actually don't look at the testing uptake, at least in the national program. I will say that in Australia, the testing uptake is reasonably high. We've got a high diagnosed population, so we think testing uptake is high. I think in terms of strategies to enhance testing uptake, we're seeing it sort of anecdotally, and some evidence as well of incentivization for people who inject drugs around enhancing testing uptake. And then some of the interventions that you saw in the systematic review, opt-out testing with consent, dry blood spot testing, point of care. Yeah, so still some work to do.
Can I add on? Sure. I just wanted to ask you a follow-up question. Does knowledge of status change behaviors that reduce risk of transmission to others, as was shown in HIV in years past?
Yeah, it's interesting. Margaret Hellard has done a systematic review of that, and the unfortunate answer is no, it doesn't seem to have a huge impact on risk behavior and sort of knowledge. Although, you get anecdotal reports of sort of sero risk and sharing, at least in the prisons, for example. So I think there's some attempt, but I just don't think we have really good data to suggest that it's having sort of population level impact.
And I would just highlight, I didn't really point it out, but I did show the data on that slide with PrEP, that people taking PrEP, there's a lot of evidence that it actually increases risk activities. So you saw that the rate of STI transmission, of bacterial STI transmission, was higher among people taking PrEP for HIV and Hep B.
You got to also, you think about a setting like the prisons where, upon entry, you do get a massive reduction in the injecting frequency of people coming into prison. But, some of the qualitative work that's been done by Lise Lafferty and Carla Treloar, essentially they're sharing one piece of injecting equipment among 10, 15, 20 people. And so the injecting sharing just goes right through the roof. So how do you, okay, fine, they're trying to serial sort, but the person who, owns the drugs or the person who owns the equipment has a different pegging order on where they inject. It's just fascinating anyway. So it's hard to change some of those.
Next question, please.
Hi, I'm Mercedes Martinez. I'm a pediatric hepatologist. Thank you for these beautiful presentations. In my clinical practice, almost 95% of my patients get hepatitis B vaccine at birth. But then when we test for the immunity, when they are 12, 13, 14, they have lost that immunity. They lost the surface antibody. Then are there any standard recommendations about checking this? I check on all the patients that have a liver disease, and I'm nervous if they get a hepatitis B exposure. Does that surface antibody negative means that they are now no immune? Many people said, oh, maybe that test is negative, but they still have immunity. Can you comment on that?
Dr. Tomei?
I don't know if Dr. McMahon is here, because he did all these Alaska cohorts, long-term immunity for hepatitis B vaccine for over almost 40 years now. And it clearly showed that even, everybody, the anti-HBs level will drop over time. And even if it drops below 10, it doesn't mean that the person is not protected. Now, there are specific groups like healthcare workers or people on dialysis where you need to check this regularly and give them additional doses to make sure that they're protected because they're getting exposed to more kind of things that might put them at risk. But in the general population so far, there's no recommendation for any kind of booster vaccination if there's documentation of previous vaccination in childhood, complete vaccination, because the anti-HBs levels are known to drop with time, and they might go below 10. But all the Alaska cohort studies so far have shown that despite the drop in anti-HBs levels below 10, the person is still protected and still able to mount an immune response if they're exposed to the virus.
Mark?
Yeah, thanks, Mark Ganny. Question. It's more of a comment and a question for Dr. Tomei. I wanted to just emphasize a point that you made on one of your last slides there about the messaging regarding the hepatitis B vaccination. I think we've erred in not really emphasizing the fact that hepatitis B virus is an anti-cancer vaccine. It's actually the first anti-cancer vaccine that was developed and manufactured. And I think many people, especially patients, don't recognize this point. And I guess my question to you is this something the CDC can take up about the messaging? Because I think if you tell people, like you showed with the HBV vaccine, that this prevents cancer, that I think many more parents would be, acceptable to have their kids vaccinated against hepatitis B. And I think really this is something that we should focus on, changing the messaging.
Yeah, I think that's quite important because HPV, that's where the pushback came from early on because it wasn't disseminated as a cancer prevention vaccine. And once they started this messaging, the coverage improved. So I think more needs to be done for also hepatitis B and probably in the future hepatitis C vaccine, because many people associate hepatitis B and hepatitis C, same with HPV, with specific behavioral kind of risk factors, and parents are always want to be like, in denial that no, my kids will not engage in these behaviors. So just highlighting the liver cancer prevention might be the best approach for that.
Thanks, Mark.
Yeah, hi, great session. My name's Nick Walsh from Australia, formerly with WHO and West Pacific, Pan American Health Organization, etc. Yeah, the question on, just a brief comment on the on people not having the titer but having protection, absolutely true, and it's true in other diseases, but we can't measure the anamnestic immune response. You just know that it does happen. But Mike, I made a comment in another session just on this issue of reinfection and new infections in people who inject drugs, because we worked on the global guide, or the country guidelines for the validation of the elimination of hepatitis, and incidence is a critical barrier towards elimination. But low dead space syringes have not been mentioned. In 2009, we produced the first hepatitis WHO guidelines, which were the prevention of hepatitis B and C among people who inject drugs. And the recommendation published in 2012 was the use of low dead space syringes, demonstrated in 2022 to reduce new infections compared with people who always use regular needles and syringes by 75%. So I just wanted to push this issue because this was expensive prior to COVID, but they were used in the delivery of COVID vaccine. If you reduce the inoculant from about 80 microliters to about 2 to 3 microliters using low dead space syringes, you get this 3/4 reduction in incidence. So I'd just like your comment on that.
Sure. Look, couple points. We've talked a lot about this. I think the first thing is that, look, even though there is some evidence around the low dead space syringes, some of it's based on observational data and some of it's based on theoretical lab data. And I agree you'd think it should have some benefit. I'd like to see some randomized controlled trials, which will be really hard to do. And so I think we still need to nail the question is, in real life, is there an impact on incidence with low dead space syringes? Now, I'm not against low dead space syringes, particularly around preferences, values and preferences of people who inject drugs, because if you offer them the syringes that they're more likely to want, you'll get increased needle syringe coverage. So I'm not against low dead space syringes, but I think we need to be a bit careful because we need some more data on it. But I think we should be advocating it from a values and preferences perspective, and so I hope that's helpful. We don't know if it will reduce reinfection, and yeah.
So ethically, you couldn't do an RCT, I don't think. I mean, you could do an ecological study, one state against another.
No, you could do a cluster randomized trial
Yeah.
where you offer low dead space syringes versus another site where they had, you had different type of syringes. So I think we need those trials. It's too bad that Unitate is not going to do those studies.
That's true. Okay, thank you.
Yeah. Good.
Thank you.
Hi, thank you for the presentation. I'm a first-timer at this meeting, and so far I've enjoyed all the presentations. Now, I work with a federally qualified healthcare center in Columbia, South Carolina. Most of my patients don't have insurance, but we do see quite a number of people with hepatitis C. About a couple of years ago, we changed some policies just to start screening universally before the task force brought out their own recommendation, and that's based on the data we were seeing. Then we pushed further to try and reduce the time it takes to link positive patients into treatment with the hope of reducing the community burden faster. And we copied that, trying to copy what HIV does with Rapid Start and things like that. Do you think Rapid Start for hepatitis C could be a potential way to achieve the elimination of hepatitis C by 2030?
Jordan, do you want to take that?
Well, I mean, I think it's an interesting point, and I think the biggest issue with Rapid Start, and I'd be interested in Jason's thoughts, but it's mostly about not losing people. So in really the care cascade, so eliminating visits is so important, and so I think the advantage and really of that Rapid Start where they gave the people the drugs based on the antibody alone initially, and the one that Jason showed, I think those are strategies to keep people in care. Most of the infections are prevalent infections. They're not incident infections. So I don't know that you're necessarily reducing transmission risk dramatically, except if you lose those people. So I think the real benefit of getting same-day starts is that you get the person on treatment and they get treated and cured, and that's a benefit to them and to the community. But if you could guarantee that they were going to come back 2 weeks later, I'm not sure it would be that impactful.
Yeah, and I think I would just add to what Jordan said. I think it's just really critical that we have the interventions in place to support people in care beyond that treatment initiation visit.
Yeah, Brian Conway from Vancouver, and I'm pleased to see a majority Canadian panel up here, assuming Jason has kept his Canadian citizenship. So my question really has to do with scalability and elimination, and there's a lot of data that I still see out there, and I'm not quoting anybody. These are all round numbers that I'm making up. So let's say you screen 5,000 patients that are a little bit difficult to find, a key population. You find 500 that are Hep C antibody positive, so 10%, so this was a good population to go into. You find 400 that are viremic. You try and find them, and you successfully find 200, and you offer treatment to all 200, and 100 of which accept treatment and complete treatment, and 95 are cured, for a on-treatment success rate, let's say, of 95%. But you still have, 305 people out there that you know are viremic, and yet you've essentially lost to follow-up within the narrow confines of the analysis that's being presented. So we're not going to be able to eliminate hepatitis C like that. So what do we do in situations like that? What is it that and people, the 95 that are cured, it's amazing that they're cured. Let's say it's a difficult population, you wouldn't have found them otherwise, and now they're cured, they're living without hepatitis C. But there's 305 more that whatever it is you set up wasn't robust enough to find them, keep them, and if we're going to scale and eliminate, this is not what we need to do. We need to get beyond that. So what do we do?
I'll start, but I'm sure Jason will have some comments. But it's a really important point, Brian. I think the one thing that's important to remember is that it's not a one-time only opportunity. We're testing it in some time of model, but when you do a cool model that looks at getting people linked to care and show that it works well, for the people that fall out of that model, there's still opportunity to re-engage them at some point. But I fully agree with you that in all of these models, we lose a lot of people, and even if you scale them, you'll continue to lose a lot of people. You just I would hope that with overlapping circles, you're finding people in different ways, and that different models will find different people and will work for different people at different times. Like someone might not be ready for treatment now, but you might engage them again in 6 months or a year, and still bringing down the population prevalence and the population viral load reduces transmission, reduces new infections. I totally agree with Jason. We won't treat our way out of these to elimination.
Yeah, I think it's a really good point, Brian. And I tried to make the point, the one slide I didn't show from the systematic review is if you do multiple things, that obviously gives you the best effect size in terms of your impact on treatment initiation. It's a bit of a no-brainer, but we sort of adapt our models to make them work. But to give you an example, we've just finished a study, 35 people, we gave them $200 at treatment initiation, $200 at completion, $200 at cure, 100% treatment uptake, 60% treatment completion. So that's why I tried to emphasize the point about we have to be doing, and I talked to the nurses, what could we have done? Jason, no amount of money would have sorted out. We were sort of, it was prison for this. So, but that's why I mentioned the patient navigation component. We need other things to support people through treatment, and it's not going to just be money or just be that.
If I may add, I think ultimately if we really want to achieve elimination, we need a primary preventative vaccine to actually prevent infection to start with.
Totally agree.
Because if we look at the rates of reinfections among people who inject drugs, it's quite high in some settings. So we're not going to achieve elimination with the available things now. We might need something else to kind of achieve elimination.
Yeah, that said, I do think the goal for reductions in mortality is fully achievable because you have this long latency period and you have multiple opportunities to test people and treat them before they develop severe end-stage disease and liver cancer. So I think that objective should be really front of mind, particularly for this audience.
Multiple reintervention seems to be the theme of the answer.
But we have to scale. Brian, you're so right. We are not, if Homey's data is correct, which probably is, we're not keeping pace with the numbers of treatments globally to reduce the number of new infections, to keep pace with those number of new infections. We've got to get real around scaling up these interventions, or we're not going to achieve the WHO elimination targets by 2030. It's a pipe dream. And not to be too negative, but we have to invest. It's not a negative thing. We have to invest more efforts to get these interventions at scale.
Okay, I'm a little, now I have to do a little timekeeping here.
So 5 minutes. That's
Because
enough.
we still have 2 more questions, and I want to make sure we get to them, so please.
So I love this. We're talking about people with Hep B cure still need a vaccine. And then those of us with the vaccine on the Hep B side, it's also still not good enough, right? I think like we love vaccine. Vaccine's obviously the main thing that's kept all these acute infections down, but we still have acute infections. And so I think we need to think about broadening our tool belt for Hep B as we have with Hep C and so many other diseases. And I love that we're talking about treatment as prevention, because I think that's been kind of in the blind spot for Hep B. Because we have vaccines, I think we've hinged all of our hope on prevention on vaccines, except for mother-to-child transmission. I think we're using treatment there. And I think this idea of like, can't we use treatment for other ways of transmission, specifically horizontal transmission? So that one slide that Jordan presented was fascinating, right? People on PrEP to prevent HIV also had a reduced incidence of Hep B. That's really interesting. We also use HIV PrEP as PEP, post-exposure prophylaxis. We haven't thought about that, but this comes up in healthcare settings, people who get needle stick injuries. Like, is this potentially something else we can add into our tool belt? And I just have to say, like, for horizontal transmission, this is something that for patients, and I'm a patient myself, and we've seen so many surveys from people who, like, the fear of transmission outweighs the fear of like the symptoms of Hep B themselves. And it has such a stigmatizing mental health burden on them, keeps them from being in relationships, getting married, having kids, pursuing professions. And so I think it's a very real thing. People are afraid of transmitting. So even though the mice model shows that we cannot completely, I still think if we're using treatment to prevent mother-to-child transmission, it should be something we think about. Not in every scenario, but I think in certain scenarios it could be really transformative for patients, just as it is for people with HIV. And I just think there's so many scenarios of people who don't respond to vaccines, or you're in scenarios where you cannot make somebody get vaccinated, or you may not be having a conversation with your sexual partner about vaccination, where you want to do what you can to prevent transmission. This is something we should think about. Thanks.
Good point. All right, you have the last question.
I'll make it quick. So I have one comment and one question. One comment is, the slide says $1 invested in AASLD Foundation leads to $6 in NIH funding. That suggests causation. I think there's a correlation there, but it's not causing. So just if we can clarify that, it may lead to $6 in NIH. Question for Rania. Fully agree with the 3-dose vaccination, infants and adults as well. If the mom is negative, hepatitis B negative, what's the rate of transmission from mother to infant for hepatitis B?
There is no transmission from mom to infant if the mother is negative, but there might be horizontal transmission if there's somebody in the household that has Hep B. So the reason for universal, many people say, oh, why are we vaccinating everybody? We just have to screen the woman and vaccinate the children of the women who are positive. But there's a lot of studies that have shown many of these women are not getting screened first. So you miss that risk factor. So that's why universal birth dose was implemented, because they were kids who were not identified as being at risk of exposure to the hepatitis B surface antigen because the mother wasn't screened. So that's why universal. And the second one is in many high prevalence settings, you have also the horizontal transmission component, which might be happening in the house. It might not be from the mother, it might be from somebody else, it might be from the grandmother, it can be from somebody else in the family when you have like multi-generational households living together. So that's why you have these universal birth dose vaccination recommendations.
So that is a fear. The household transmission is a huge fear. In many countries, they do have 3-dose vaccination. And in fact, the baby receives the first vaccine within the first 6 weeks. Are there studies that looked that if they don't receive the birth dose, what's the rate of household transmission if they receive the full 3-dose vaccination?
Yeah, I think there are several studies that probably will be disseminated soon. I know many studies. I think Dr. Ward is working on some with, I think, Imperial College and others have done like Gavi-funded studies. We've done some study also as well, which will be disseminated soon. So there are studies which will be published soon showing the rate of mother-child transmission, especially in sub-Saharan Africa where there's no birth dose vaccine available.
But Homi, are you asking the difference between birth dose versus infant dose?
Yeah.
Like, and whether, okay.
Yeah, whether the infant dose actually prevents household transmission. Yeah. So we'll look forward to seeing those studies.
yeah.
Thank you.
Yeah.
Oh, it's John.
I'm sure infant does. I mean, immunization does prevent horizontal transmission. It's just a concern that if the baby doesn't receive the newborn vaccine, then they become a subject of horizontal transmission when they, are in the household. If that's what you're asking, the risk of the newborn, and the birth dose prevents early horizontal transmission that the infant immunization would miss because of the timing of the vaccine.
Even in presence of a first dose. Even if the baby received the first dose, not within the first 24 hours, but within the first 6 weeks, they still
Yes, they would be at risk for horizontal transmission in that 6-week interval, absolutely.
Look forward to seeing those studies. Thank you.
Okay, sure.
Okay, so we're at time. I want to thank the panel, outstanding presentations, and really want to thank those that remain. But we had really a lot of interest in this session. It really remains our challenge. And I think we didn't have all the answers, but really, again, raised the bar, right, in terms of what we need to do. John, as the co-organizer for this, I'm going to give you the last word.
Okay. Well, thank you. We did have a great discussion. I want to thank all the panelists. I do want to leave everybody with a little ray of optimism. What I was trying to point out that actually we have averted millions of infections over the last years, and we're continuing to do that every day. It was just that we're really focused on these really hard areas now, that we've done a lot of good work that's been very productive in improving health around the world. We just want to continue that, assignment and really reach these elimination goals. But I think we should be very proud and very optimistic about what we've achieved collectively as a community interested in this, and while recognizing we need to continue to be commitment to reaching these other hard-to-reach populations and incorporating new technologies and strategies that we're finding and sharing at events like this. Thank you.
Great. Thank you all.